guys for having me. I am so in awe of this organization. I was telling Mary as we were just getting acquainted, just kind of thinking about what tremendous impact you guys have made. I mean, this is, I don't know how much of the rest of this organization you know, the other chapters and the national body of the organization, but this is a really amazing organization, Bobby Jones, Chiari and Syringomyelia Foundation. The Mind Institute is only 3 years old. You guys are almost 20 years old, and the difference shows. I mean, you guys have an amazing outreach. You have tremendous impact, and the things that I could only dream of, you guys just do it like it's just kind of easy, but it's not. Coming from someone who has done this and kind of been at this for just a few years, what you guys are doing is just quite amazing. So I was just standing here asking Mary, like, give me, in the 5 minutes you have with me, please tell me everything you guys are doing, and how do you do this? How do you do so many patient events, like the walk on Saturday, right? It's Saturday. How do you do that from New York, and how do you organize it? And there was so much I wanted to know, and still so much more I want to know. But I'm so honored that you would have me as your speaker tonight. I just consider this to be sacred ground, and just very, very honored that I can speak in front of this distinguished group. So thank you very much. This means a lot to me, so thank you. I'm going to bring up let's see here. Okay, there we go. Okay, I'll try to stay in one place, that way I won't disturb the sound. When I started thinking about this talk, I thought maybe the title, Measuring What Matters, might be something that would land on this theme of very specific measurements. You guys have been in doctors' offices where they're drawing things out and they're measuring this, and you have this so many millimeters and that so many this. And I thought I would just kind of talk a little bit about, what does that mean? What's going on in a doctor's head when they're sitting there and giving you all these diagnoses, and some of which they know and some of which they don't know. I thought someone would raise their hand, but they didn't, so I'll just point it out. You didn't see Chiari malformation on that list of things that I'm an expert in, right? So what am I doing in front of you guys? And don't worry, we will get to that part in just a moment. But that's actually it kind of plays into the theme, right? Because not every doctor is going to be trained in Chiari malformation, or Syringomyelia, or any of the other list of things that you guys suffer from. And so I think it's important to have someone who's willing to kind of learn and step outside of their area of their comfort zone, but then be humble enough to say, well, I probably need to bring in some experts. So we'll certainly talk about those things. I wanted to just take this opportunity. Well, sorry, the fact that I had been asked to give this talk gave me an opportunity to learn. So I learned a whole lot about your organization, but it's kind of starting with Bobby Jones. And gosh, I didn't know that he had helped design the Augusta National Club. I was born in Augusta, Georgia. So that really hit home for me. And then I didn't know that he was an amateur golfer, but he was playing against professional and winning, tournaments. And then of course this untimely, Syringomyelia that he came down, was discovered and caused him to have to retire. And so as the leader of an organization, I am really into mission statements, and I just, kind of looking at your mission. Each one of those words matters. So awareness is a whole thing. If you're not in the nonprofit world, awareness means you've got to spread the word, and that takes a lot of effort to do that. And I would just say, by the way, that when you said, Nancy, about now you're starting to see physical therapists, and now you're starting to see physicians and so forth, that's awareness. You're creating awareness. So you guys are really excelling at that. I thought it was really cool that you guys are the highest rated charity with regard to these designations with Better Business Bureau. Again, I would love to have that designation. I'd love to have a 97 out of 100 charity navigator score. We aren't even on any of these maps, so I was like, well, That's nice to aspire to that. But you guys have done it. You've done this. This is not aspirational for you. You've achieved these, and you don't do that without a lot of hard work and a lot of dedicated individuals. I'm not putting it up here, but I did just kind of look at your audience. Who do you serve? And it was, everyone, patients, of course, educators, policymakers you talked about, families, caregivers, and so forth. And then you're also really covering a lot of ground. So not only Chiari, malformation, and Syringomyelia, but man, when you throw EDS in there, I mean, okay, you've got the whole bag. Plus dysautonomia, POTS, and so many other really important diseases that don't always get the acknowledgement that they should. So I'm just glad that someone has seen that this group really needs to be elevated so that they receive the attention they should, and I just think that's really important to point that out. Just looking through your website, I noticed that there are at least 4 on this one slide here of folks that are connected here to MUSC in Charleston in particular, including Fraser Henderson, who trained here as a resident, and then his son just finished a few years ago, and Brandon Miller, who's my colleague here. He's also just joined the faculty here. Chip Norris, who of course is here and heads up the EDS lab here, and then Eileen Ruhoy, who I'm not sure if she's here yet, but was transitioning here to help with Ann Maitland's EDS Institute. And so there are, just reading through your board of trustees, reading through your scientific education advisory board, your board of directors, I was just really impressed at the breadth and depth of who you guys have recruited. One quick note on your, again, your just kind of mission points here, your pillars. I just was so impressed with, what you guys have been able to accomplish with all of these various studies, the groups that you guys have partnered with, their awards that you give in recognition of research in these areas. I put the podcast and videos at the bottom because I wanted to, got super interested, and I listened to one of the podcasts. Is called the Chiari Champion. I was so impressed and blown away. I actually want to, if you've never taken the opportunity to listen to this podcast, you should. I listened to just one episode, and I thought I would play maybe a little small clip. I'm going to play it on my phone because I can't play it here on the computer. So if it's okay, I'll just use the microphone here. Let's find out here. Let's see, maybe. Sorry, give me 1 second here. I'm just going to pull this up. There we go. Okay. So the episode that I listened to was of a lady whose name is Funny Mother Tucker. This was back in July. And just listening to that, I don't know if you know her, but you do? Yeah. Okay. So I learned halfway through the podcast that she's a stand-up comedian. That's how she gets the Funny Mother Tucker. But she has over 10,000 followers from TikTok, and I would love to have 10,000 followers. I'm going to play just a small, maybe just a couple of clips that I think are interesting and relevant to this talk. Hopefully this will work. So give me just a moment. See if I can cue this up here.
Welcome to the Chiari Champion. My name is Noah Foreman, and today I have with me an awesome guest. Her name is Beth Tucker. Beth is a 24-year conqueror and champion of Chiari malformation, Syringomyelia, and EDS, as well as a long list of comorbidity suspects. But she wants you to know that this is not a contest. However, if it were, ding, 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 she would be the unlucky winner of 2 VP shunts, a cranio-cervical fusion, a cerebral stent, and more trips through an MRI machine than one person should have in their lifetime. Welcome, Beth.
I mean, only a Chiari, EDS, or CCI patient, first of all, would even know what those terms mean, but they would totally get just that little introduction there, right? That's a lifetime for her. And she detailed what I thought was interesting is that she talked about in the 90s, which I just hadn't thought about this, and it actually makes a lot of sense. In the 90s, remember, those were HMO days, where they did not want you to have an MRI. Today, it's the opposite. You're supposed to get an MRI before you see your primary care or the specialist. But in those days, you were discouraged from getting one. So she had a really tough challenge just kind of navigating that. When she kind of, there were ups and downs, and she describes that. There's one point in this podcast where I think he asked her, what would you tell people who are just diagnosed with this? And she says, I hope I'm quoting this correctly, she says, suffering is inevitable, but misery is an option. I just thought that was very poignant and, again, very relevant to our discussion tonight. And I looked that up. Again, I got so interested, so I learned so much. And it comes from, like, Buddhist traditions, Stoicism. There's quite philosophical, this notion that she mentions. But, again, this is someone like all of you who have been through, dozens of doctors and lots of misdiagnoses, and you had to kind of find your own path, and so that's what we're going to talk about tonight is just what does that look like, and why is that? And so we'll just try to explain some of that to you, or not to you. You'll explain it to me, actually, because that's kind of the point of the talk, is that I want to learn from you. Last but not least, so you have a long list of videos on your website. So I also listen to that. And this is a gentleman, Eric Jackson. The title of this is something to the effect of 100 most asked questions about Chiari. If you just look on that list, you'll see it. It's sort of in the middle. And I clipped this screenshot because, to me, full disclosure, I saw a Chiari patient in my office yesterday. New diagnosis. She started out with a very tearful story about how many doctors she had seen to get to me, and she was even more so than she actually didn't care about her diagnosis. She was very upset and hurt by the fact that the doctors never told her she had Chiari malformation when she looked back at her records, and it had been on there for some time, and after several doctor's visits, no one informed her of this diagnosis. And so when we talked about it, we kind of came up with a plan, and she felt like, she said, I really trust you, thank you for listening to me. And so we kind of got through that part. But I just tried to help her understand that I don't think anyone was intentionally trying to keep anything from you. And she was saying, but why didn't they tell me? Why didn't they know? This was just yesterday. This is just yesterday. Just walked in my clinic. And I said, I think they just literally didn't know. I don't think they tried to ignore a term that they thought was scary and didn't want to share it with you. I literally think they did not know what that meant. And that's exactly what, by the way, this funny Mother Tucker says, is that one doctor didn't know, and then they called another doctor, that doctor didn't know. And so even in 2025, this is actually still not an extremely well, speaking of Chiari, Syringomyelia, forget about it. Just stick with Chiari, and again, EDS, don't even think about that. So, I think, again, the awareness part of it, the advocacy part is really critical, and what you guys are doing is really amazing. So I thought what we would do, and I'm speaking to already a lot of professionals, Michelle is a physical therapist, Okay, all right, neuroscientists, I'm sorry. But you guys have so many professionals in your group, people who are patient scientists and physician scientists and people who know this area very well. But I thought what we would do is maybe build a neck together. I want to show you what I see when I look at images at someone when I'm thinking about Chiari. Maybe the question is, how do you, with all this other expertise in different areas, how do you look at it? So I want to just do it together. Okay, so let's build this. Let's build it from scratch. We'll construct a neck and see what it looks like, why it looks the way it looks, why it does the things it does, and then realize that really Chiari is sort of on a spectrum of things that can happen to the neck, constructed in the way it is. Okay, so I won't take up a lot of time, but we'll just kind of talk through this. I'm going to use my mouse as my mouse as a pointer. Let's see, let's go back to this laser pointer here. So, all right, so this is just a standard picture that we as medical students look at all the time. It's our Netter's Atlas, and Netter was a famous anatomist, and if you're looking at this picture, you're kind of seeing that the cervical spine, I'll just stick with the cervical spine for now, is built for two things. Strength and flexibility. So your body's trying to do two things. You need to be strong, but also have some flexibility. So what it does is it just has points of contact with other bones and tissues, and all of those things can go wrong. And even if one thing goes wrong, that kind of sets off a cascade of events. And so very simply, and again, you guys know this better than me, so I consider you to be the expert. When I look here, you're not looking at everything, but this is C1, so this is the posterior arch of C1. And so you don't see the anterior portion, it's behind the styloid process here, but this is C2, 3, 4, 5, 6, and 7. So we'll just kind of we'll keep our comments just relevant to that. And then there's the skull, and the skull is actually built to fit right on top of the spine. I'll show you what that looks like in just a moment. Okay, so if we start deconstructing this, where the skull is connected to the spine is this little piece of bone called an occipital condyle. Okay, an occipital condyle. And the occipital condyle, if you were to turn the skull and put it back on the spine, it looks just like this guy here. Okay, so it sits in like a little groove on the top cervical spine, which is called the atlas. Okay, and then that's supposed to just kind of stay in place. All right, so that's going to stay in place. So that's going to be kind of that first point of contact. And then if you just, again, before you kind of really get into the spine, if you just think about how it's structured, look at all those ligaments. I mean, that's a lot of ligament. And when we're doing surgery, we see every one of those ligaments. This is called the interspinous ligament here, this large set of fibers. And then you've got some on the front, which are these guys, this is called the anterior longitudinal ligament. So, again, it's sort of like trying to stabilize the spine. And if you look on the inside of that picture, there's also a posterior longitudinal ligament, or the PLL. If you turn the head around, you've got, again, more tissue that you've got to get through. These are all ligaments that are holding these together. And so it takes a lot of energy, it takes a lot of force to try to pull those away. So if you are having cranio-cervical instability, and we're going to go over that in detail in just a moment, it sort of has to be from either an injury or failure of all of these ligaments. They have to, because they're redundant. There's like multiple, if one fails, you really should have 2 or 3 backups. But once those backups are exhausted, then you have what we have, which might be Chiari, it might be Syringomyelia, it might be a number of things. And again, I'll show you pictures of all those things, okay? But again, before we go on, just know that even as neurosurgeons, when I'm looking at this in the operating room, it takes so much force for me just to even get to, from the surface of the skin, which might be here, all the way down to, this area here. So there's just a lot of redundancy that the body is building up. The thing that I do want to make sure we talk about before we kind of get deeply into Chiari malformation itself are these ligaments here. So if you were to kind of look on the inside of those bones, again, there are redundant ligamentous fibers. One of them is called the cruciate ligament. It's there's like a cross here, and that's why it's called the cruciate ligament. And it connects the top of this C2, which is the dens. The whole thing is called the odontoid process, but the top is called the dens here. And it has this ligament that connects to that and the foramen magnum. Okay, so I know you guys know what that word is, and we'll talk about what the foramen magnum is here in just a moment. But then you've got something called the alar ligaments, and that connects, again, directly from the dens to the foramen magnum. So just the skull itself connecting to the spine has at least 4 or 5 sets of ligaments. some that are vertical, some that are transverse, some that are oblique. And again, it's built to try to keep the head mobile, but also strong enough to carry the weight of the head. All right, so that's kind of the anatomy lesson there. Let's see, I think we've probably, and this is what this looks like. If you take off all the ligaments and you kind of deconstruct the spine, this is actually what it looks like. You don't need to worry about all the different labels here, but just know that this dens process kind of sticks up and connects the C1 ring, and then the occipital condyles are contacted here, and this is where the skull sits. Okay, so if we were to kind of go backwards now, back to where we just kind of started from, if you were to sit the skull right on top of this structure here, and then you put ligaments around it that allow it to some degrees of motion to rotate up and down, and then left and right, and then also to kind of stay stable. That's the way it should work. Now, it doesn't always work that way, but that's the way it should work. Okay, so that's kind of our foundation. All right. Again, forget about the labels. Don't worry about that. The reason I'm showing you this is because if you look at the skull, the place that we're going to talk about, which is when we talk about Chiari malformation, the 2 points I want you to be aware of are this structure here, which I know you guys all know. This is called the clivus, but there is a tip of the clivus, and it's called the basion. Okay, and that'll become important in just a moment, the basion. And then on the other end, the very tip of the back of the skull is called the opistheon. And that's not even labeled here. I didn't even know what that term meant until I was studying for my boards. The opistheon and the basion. And that forms a ring, and that ring is the foramen magnum. And through that can push through some of the brain. Okay, so that's kind of where Chiari malformation starts. All right. So I thought what we would do is, this is a standard MRI. This is actually from my clinic. So I looked at a bunch of MRIs online, and most of the images you see are going to just be from Google. This one I just needed kind of a nice MRI. Does she have Chiari malformation, by the way? What do you think? What do you guys think she has Chiari malformation? Okay, all right. What kind? What type? So, whether she had, this is the issue with Chiari malformation. Whether she has it depends on a measurement. And you guys know the 5 millimeters. I'm sure all of you know, you've heard this from doctors, that it has to be 5 millimeters from the foramen magnum. And how do we measure the foramen magnum? Well, we just simply draw, this is how simple doctors are. We just literally draw a line. That's what we do. That's just how simple this is. And we draw it from the opistheon to the basion. Okay? There. Okay, that's called McRae's line. Now, the one thing I should have pointed out, and I didn't, you don't see it here, is the hard palate. Well, you do see it here. The hard palate, which is here, you know what, let's just talk about this. So let's just say that this MRI, the radiologist reads as 5 millimeters from the foramen magnum equals Chiari malformation. What would I have to do to make her not have Chiari malformation? Just think about it simply. I could either raise her skull up to where it's 4 millimeters from the foramen magnum, or I would have to leave the skull where it is, and shrink the tonsils back up to 4 millimeters. Right? It's that simple, and that's the reason why a measurement-based diagnosis can get you into a lot of trouble. Okay? Because, and by the way, she certainly has Chiari, but it's really the symptoms that really drive home the diagnosis. Okay? Having said that, when you start to think about the failure of all of these different ligaments, how the neck can shift forwards, how it can shift backwards, you can start imagining a line from not just this McRae's line, but you can measure it from the hard palate here, and this line here is called Chamberlain's line. You don't have to worry about the historical significance of that, but other people use something called the McGregor's line. I'm going to show you this in another picture here. Some people get really, sort of fancier and look at the length of this, sorry, not the length, but the distance of this, the back of this axis, this C2 vertebrae that we talked about. So that's that line there. And then if you measure the angle of the clivus, that's called the clivo-axial angle. Okay, and you can do so many things with it. You can measure the angle itself, you can measure the interval, and people get super duper concerned about what those, I shouldn't say with good reason, about what those angles mean. Because for some it means surgery and for others it doesn't. Okay? All right. So this is just something I found on the internet. It shows these, but I wanted to just build it up for you a little bit just so you'll see exactly what are they measuring? Why are they measuring? Why is it important? And by the way, when you look at the 5 millimeter designation on an MRI, that is actually what insurance companies look at to cover the surgery for Chiari malformation. That's why that's important, okay? So if it's 4 millimeters, it's called what? Cerebellar ectopia. And that is literally just a gobbledygook word that just means it's a little less than Chiari malformation. That's all it means, okay? A herniation. I think this is the last one of these I have with all the different measurements, but there's something called the Powers ratio. And if you start thinking about how these ligaments fail and the skull moving forwards, backwards, down, up, what it does is it looks at the basion to the length of the basion to the posterior arch of C1, this here, and then it looks at the distance between the anterior arch of C1 to the occiput or the auspicion. And you divide those by each other, and if it's greater than 1, then that means there could be a dislocation there or cranio-cervical instability. And we'll talk about CCI in just a moment, okay? That's a whole different sort of set of diagnoses. But that's, you can see that there's a spectrum. There's sort of, you're born with Chiari, that's just how it is, it's all fixed. But then as ligaments and hypermobility sets in later in age, you might get into a little bit of, and I'm physically stepping over because I'm just kind of tiptoeing into the CCI world. And then you might say, well, maybe you have EDS, which opens up a whole can of worms, right? Because then you're not just in the head, you're in other parts of the body. Okay, let's kind of go through some examples just so I can show you what, again, when I look at a scan, when I hear a story, I'm not trying to put it in a category, but at least I kind of know, I want to know how severe this is, okay, and what we're looking at. So I didn't put all the definitions here, I just thought it would be too much, but I at least wanted to show you when you guys are discussing Chiari and you're looking at, say, social media and someone says you have a 2 versus a 1 versus a 4 versus a 0 versus a 1.5, what does all that stuff mean? And then because there's so much lack of understanding, you may even get a doctor or a physician or healthcare provider who gives it a name. You might see something on a radiology report. There's just so much out there, and so I wanted to try to clarify what those numbers mean, okay? So Chiari 1, are you okay? Okay. So Chiari 1 is the most common. What's interesting about this is even experts today in 2025 agree we still don't know how many people have Chiari malformation. Forget the numbers. They don't even know how many have Chiari type 1. But Chiari type 1 is basically herniation of the cerebellar tonsils through the foramen magnum. And again, people tend to think that 5 millimeters is a reasonable cutoff for that diagnosis, okay? It can be longer than that, but 5 millimeters tends to be what we see. And then Chiari 2, and I didn't put the anatomy on the screen here, but Chiari 2 includes a portion of that part of the brain called the cerebellum. That middle portion will herniate through the foramen magnum, and that constitutes Chiari 2. It's called tonsils and cerebellar vermis, and sometimes the brainstem itself, okay? And what are the functional differences, Chiari 1, very rarely associated with Syringomyelia, and Chiari 2, almost always associated with Syringomyelia. And the reason being is that the pressure of the CSF tends to get forced through the spinal cord, and it creates these channels within the spinal cord. I'll show you, I think the next slide is, yeah, here we go. So, basically what you can see is that as you block this area here at the skull base, which is the foramen magnum, the fluid just simply finds another pathway. And sometimes the pathway of least resistance is actually in or inside the spinal cord itself. And so that's what that looks like. There's literally just a pathway, an open chamber for fluid to fill. And clearly as that fluid builds up, you have more and more symptoms. And so here's a small, I shouldn't say small, but we see them super small. This is probably not even all that symptomatic. A person like this probably would never even know they have this. This is a little bigger, and this of course is a lot bigger. And again, we see people with these and they're just walking around like totally stone cold normal. They don't even know they have this until they, I don't know, scratch their knee or something, get a scan in the ER, and they're off to the races. They get a scan, they see me, and then everyone just goes crazy. But what I would say is that when a person comes to me and they look like this or they have this, I don't do a thing. If they feel fine, I'm okay, just watch it. And then sometimes you do have to correct the Chiari if they have symptoms. You should know that the natural history of tonsillar descent is that they kind of go back up in your lifetime. As you get older, the tonsils just naturally go up. So if you leave it alone, sometimes it just kind of works itself out. So that's a real important consideration when you're seeing someone or surgeon about this. This is Chiari 3. Chiari 3 is when you have herniation through a skull defect. So it's a more severe form. There are many kids, and this always in kids, and sometimes they don't survive. This is sometimes non-survivable. And you actually see brain matter coming out of the skull. You see that. Sometimes, again, it's closed like a little sac here, but sometimes it's just, and you just have to excise that. And here you can see even the brain stem is just not even developed beyond the point where it's separated from the cerebellum. And so sometimes you just have to excise this tissue and then close this off and you have to just take what you can get. And so, most of those folks are obviously, they're paraplegic or quadriplegic, and they have a severely shortened lifespan because of that. So that's Chiari 3, okay? Chiari 4 is where there can be what's called agenesis of the cerebellum. You don't even have one, right? So it's a completely different disease. This is why this disease is so complicated, this syndrome, I should say, is because looks nothing like Chiari 3 or 1 or 2, right? And I remember, so my PhD was in the cerebellum, and I spent 6.5 years of my life dealing with the cerebellum, and I remember at my thesis committee meeting, I spent a whole hour trying to convince people defending my thesis that the cerebellum is super important. And the first question out of my mentor's, or he should have been my mentor's mouth, was, well, you know that some people are born without a cerebellum, and so how do they survive? And I was totally floored. I was like, that's the one question I never expected to have. But he taught me a lot. And that was 20 years ago, and I still remember it. So if you're born without a cerebellum, without getting to a long academic discussion, a lot of the brain can compensate for some of those functions. Okay, let's just put it that way. But if you hear that someone has a Chiari 4, that gentleman that I showed you, that screenshot of the expert at Stanford who was talking about, Chiari, he says in his career he's never seen it. That's how rare this is. Super rare. Super rare. And what is Dandy-Walker syndrome? I know you guys have heard of that. Dandy-Walker is upward herniation of the cerebellum. That means it goes, instead of going down, it goes up this way. Here's the cerebellum right there. Okay, actually the cerebellum's kind of here, and part of it's there along the occipital lobe. These are all severe congenital childhood or neonatal malformation. So these are things that would be seen on an ultrasound and be discussed for a long time before a child is born. I want to give you just a few more variations, because these are all variants of a theme. They seem like they're totally separate, but they're all variants on a theme. Okay, when you have breakdown of the ligaments and stability, this is what happens, okay? You can go up or down. So this is something called basilar invagination, and this is when the skull actually settles down so far that the dens actually pushes into the brain. And this seems like a really severe case, but it's actually, we've seen it even worse. We've seen those odontoid go right up to the third ventricle and the thalamus, okay? And how do you fix that? You literally have to cut all those ligaments and reset the skull. And I'll show you some severe forms of that in just a moment. You didn't hear, well, you may have heard this on that clip that I just played of the podcast. This is called a retroflexed dens. Retroflex just simply means it bends backwards, and it actually digs, for lack of a more scientific term, digs into the actual brain stem. And then, yeah, of course you're going to get Chiari because the brain, cerebellum, has nowhere to go. So it herniates through the foramen magnum. But this is all caused by this. And how do you fix this? Well, you have to go and cut it out. And how do we do that? Actually, through the mouth. So we open the mouth, we cut the back of the throat, we drill out this dens and close it back up. And then we decompress the brain stem. Okay, did a couple of those in residency. All right. Talking about cranio-cervical instability. So I showed you how the atlas, which is C1, wraps around and articulates with the dens, that little process that kind of goes into that groove. But if, for whatever reason, the alar and cruciate ligaments relax, well, what do you think happens? Well, they separate. And that, again, that C1 is called the atlas. So if you look at the ADI, which is the atlanto-dens interval, if you get beyond 7 millimeters, again, here we're measuring things, that is an indication that when you have flexion and that dens open, as that interval opens up, that's sort of the definition of CCI, cranio-cervical. If you ever, I know this group has heard that term, but understand, first of all, it's an umbrella term, so it doesn't mean anything specific. You have to kind of think about, well, what's unstable? And so you kind of get into a few technical terms there. But I'm just showing you, in case anyone here has anything like this occipital cervical fusion or OC fusion or cranio-cervical fusion, those are all terms that basically mean the same thing. This is what this looks like. Okay, this is what this looks like. It looks like a plate on the back, a screw in each of those first 2 vertebrae, here the first 3 vertebrae, and then connecting it with a rod. And after you do that, you can't move your neck, right? So that's a look, for 5 millimeters versus 4 millimeters, you better be measuring correctly before you subject me to something like that. And so I've done a few of these. These are never satisfying surgeries for me, at least, because no one likes this. No one comes back and says, oh, I've had one, but beyond that, most people are not super happy with this long term. So this is why awareness, research, cures are needed. I want to just talk about some very severe forms. I mean, we're way out here now. We're so far away from Chiari, but I want to just show you before we move on. This is called atlanto-occipital dislocation. This is when your neck is totally broken and completely dislocated from the skull. This happens when in severe car accidents, motorcycle crashes, when people jump off buildings, jump off bridges, things like that. When we see them in the ER and we look at their neck, it's totally dislocated, right? Just think about that. There's enough energy that you can sever all of those ligaments. And how's a person living like this? Well, you have to remember that these are only the people who actually come in. Most people are actually expire from an injury like this. This person, I think this was a child abuse case, I think, and this is just complete dislocation of the head. And then again, you saw that this is what it should look like. This is the occipital condyle. This is C1, and you can see it's just completely dislocated. And we see these a lot in various forms of trauma. On the other end, we see in degenerative cases, this is called chin-on-chest deformity. We see this a lot. This is not really one of those variants per se, but we do. I remember very distinctly, there's a guy that went to my medical school, and he walked around like this, and he just existed. I mean, I was like, that looks painful to me. But he just this is just how he lived. He would open doors like this. He would work like this. He'd go to his car like this. I don't know how he did it, but some people can live like this. And the reason I'm pointing this out is because you not only have that occipital cervical fusion, but you kind of have to have this fusion kind of all the way down the spine. And so this is a much bigger surgery than what we would do for, say, CCI. But you just kind of have to think about all of these things from a Chiari 1 would be the simplest, in my opinion, explanation at least, all the way to kind of what you're seeing here. And if you think about how the skull is constructed, you can kind of see how failure of some of those systems, those redundant systems, leads to this sort of picture. Okay. Now, if that wasn't enough, just think about the explanations that people have for what causes Chiari. I hope there's no one in this room who gets offended, but I would just say, reading through this, it just gets to the point of absurdity. You saw the kind of devastation that you can have if you have one of these things that's going on. And people have, bless their hearts, they've tried their best. Scientists have really tried to understand, well, what happens, what causes it? Well, it probably is something that happens in the embryo, and there are these various explanations as to little micro fluctuations in either pressure, various layers of the embryo that fail to form correctly. That sets off a cascade, and then you kind of have what you have at the end of development. To me, I guess, again, just kind of I'm just a simple functional neurosurgeon. What I would say is I think you can kind of, if you think about just fixing those ligaments or being able to have the ligaments not fail at various points in development, you probably are not going to end up with most of these theories needing to be advanced. Although one of the things I will say that I thought was interesting is if you have a small part of the back of the skull, which we call the posterior fossa, there are various things that can lead to a small posterior fossa. And that does make sense that if you have a normal sized brain but a small posterior fossa, some of it is going to hang out and cause Chiari. Okay, that actually makes a lot of sense to me. So when we think about the mesoderm, which is the layer of the embryo that contributes to bone and muscle, and if that fails, I totally see how you could just have, Chiari at a very young age and end up with a lot of the things that I showed you. All right, I'm almost done. So one of the things I'm a huge proponent of is trying to look at the big picture, because that's typically what we do, at least in our organization in mind. We have as our pillars not only EDS Chiari, but stroke, glioblastoma, which is a malignant form of brain cancer, chronic pain. You wouldn't believe just the community that exists in chronic pain for all sorts of various reasons. And when you look at that, you start to see commonalities. You start to see common threads between different groups, and also lots of differences. But this paper came out in 2024. So this was in 2021, but there's a follow-up in 2024 where the Lancet group just looked at all nervous system diseases. We're talking about everything from Alzheimer's to neonatal meningitis to neonatal encephalopathy to seizures, epilepsy, Zika virus, literally from A to Z. And what it found, to my surprise, is that if you look at the prevalence of all diseases, literally everything, knee pain, back pain, the whole thing. Of course, the highest prevalence of disease, of any disease in the human body, what do you guys think it would be? Any disease, any part of the body. What do you think? You've got skin, which is a huge organ. You've got liver. You've got your digestive system. What do you think? The heart. I'm sorry? Okay, I love that idea because it's sort of inflammation, right? The immune system. So the one disease that has always, and since time immemorial, been literally the top the most frequent disease ever, is ischemic heart disease, right? Just think about cardiovascular. You know, the heart is one organ that all of them have to work all the time, but the heart, you know, probably expends the most energy doing that, with the exception of the brain. But ischemic heart disease is just, you know, that's the thing that the CDC, was set up for, and in most, you know, medical, you know, when people were kind of thinking about health as a public health sort of thing, cardiovascular was always, you know, heart attacks for a long time was always number one, and it still is pretty much the number one in terms of the number one top cause or top mortality in the world. But if you look at disability, not occurrence of disease and not even death from a disease, but you look at disability, you can look at it in lots of different ways. You can look at years lived with a disability. You can look at years lost to a disease, and you combine those, you come up with something called DALY, which is disability adjusted life years. And if you look at, again, all diseases, I mean the immune system, the digestive system, every single disease you could ever think about, the neurological diseases actually wins out over cardiovascular disease by a little bit, okay? And so it turns out that if you just combine every neurological disease you can ever have, and by the way, Chiari, I checked, of course. Chiari is kind of like in the middle of those, so you've got stroke at the top, and you've got some other really weird, rare things. But Chiari is about in the middle. I mean, that's a lot, right? That's a lot of disease burden to have amongst all neurological diseases. And so that means there's a lot. Neurological diseases are really tough, especially most of them are chronic and very difficult to treat, and we don't have cures for the vast majority of them. My message today would be, you know, when you think, and I shared this with the patient yesterday, when you think about, you put your team together, you've got a big team. You've got a neurosurgeon, you've got a neurologist, you've got a physical therapist, you've got a neuro rehab specialist, you've got, you know, rheumatologist probably, you've got a geneticist. Who do you think, and you've got your, you know, family and support systems, of course, who do you think is like the most important one of all those experts? Who do you think? Throw out a name. Give me a specialty, or who do you think is who creates the most impact in your disease? Neurosurgeon? Anyone else? I hear of some neurosurgeons. Okay. Here's what I know. PT? Yeah. I love it. Okay. Look to your right. Look to your right. Look to your left if you don't have a right. Look ahead of you. Now look backwards. It turns out that support groups and support structures are actually the most important part of your therapy and your recovery and healing. So many people, the person in this podcast said that, my patients say that. I had a lady with traumatic brain injury who came to me from a different state and had just, hadn't been treated for a long time. She was kind of in a panic, and we kind of got her, we set her on the right path, and I sent her to a lot of people. And at some point she said, I don't think I need you anymore. She says, I met this, so I connected her with a support group. She said, well, and I happened to just go to that support group and she walked in. And within like 5 seconds of her being there, other people with traumatic brain injury showed her, just to give you some specifics, she said, after my traumatic brain injury, I can't tell my left from my right, and so I'm very dyslexic. I'm very ashamed of going places because I have to explain why I always arrive late, and it's just very socially embarrassing, so I tend to kind of stay at home. And then one lady who was, 70s or 80s, she said, you realize you have a ring on your left hand, right? She's like, oh yeah. Just look at your hand every time you want to tell the direction. She was like, oh, I never thought of that. This lady had to travel from another state to come here. Within 5 seconds, she basically figured this out. And she told me, she said, well, I have my support group now. I don't need you anymore. But before she told me that, I already knew that. Neurosurgeons are not the most important, I might say as you're sort of getting a diagnosis and trying to get yourself stabilized. But I mean, neurosurgeon's not going to walk with you for the rest of your life, right? They're going to do one thing and then they move on and you move on. And if they've done their job correctly, that gets you to the next stage. But your family, your caregiver, your social support, those who love you, they're going to be the ones who kind of walk with you through the ups and downs. And there will still be ups and downs. We just have to kind of, again, I don't have to tell this group this, you guys know this very well, but I do think the paradigm and around awareness, we have to, I don't know where this whole thing about neurosurgeons being so important, I don't understand, because I never thought that even before I was a neurosurgeon. I would say that we play a part, and neurosurgeons, yes, okay, they have egos, and sort of thing. But they are not even close to being as important as they think they are. Don't tell anyone I said that. I think that I always think about life and the people who come into your life as a play. If you've ever watched a really good play, and I don't go to plays all the time, but I've seen like really good plays that I got into and I was really invested in the plot. If all of the people in that play just stood on the stage at the same time, there wouldn't be a play. There's like no timing to it. No one comes in and out. Someone has to go off stage, right, for the thing that makes sense, right? And so I think neurosurgeons are just part of that play. They come in, but they have to go out for it to have meaning so that at the end, you then get to have this rousing celebration and ovation for the journey that you've been on. And I think that that's just kind of a paradigm shift in thinking around kind of integrative medicine and what roles each person plays. So as I close, I would encourage you to just keep doing what you're doing. One of the things that I have found that now this is my turn to turn it back on you guys. When you ask us, hey, why aren't you doing more? You should know about this Chiari malformation. A lot of times I might tell a person with Chiari, all of the suffering that you've been going through, would you come to a support group meeting with a patient with malignant brain cancer who only has 12 months to live? No, I don't do that. I don't have that. I have Chiari. I don't have Alzheimer's. I don't have stroke. I don't have chronic pain. I don't have Parkinson's. I don't have any of the other diseases that we treat. I said, but you guys are in the same, you're in the same bucket here. We're all trying to, help each other. No. I've even talked to doctors who didn't want to be in the same room with another doctor who had maybe a slightly different specialist. Was talking to people who specialize in MS, and they said, no, we don't want to be with the ALS people. That's ALS. We're MS. Multiple sclerosis. We have nothing to do with them. I was talking to a spine surgeon. I said, will you please present on spinal cord injury? I don't do spinal cord injury. I have nothing to do with spinal cord injury. I said, bro, you're a spine surgeon. Yeah, but I don't treat that. So I think we have to just, again, change the paradigm. You might meet a person, you're going to live with Chiari and someone's going to eventually figure this out, but a person with GBM is not going to be around in a year. They're not. So every word that you say, they hang on to. And when we shift that paradigm, and again, we can open this up to everything: diabetes, heart disease. The circle gets wider and wider. I want us to kind of think about our brothers and sisters, and the people to our left and right, and then the back and in the front of us, because those will be your kind of glue. That's going to glue you together and get you to that next stage. And when you listen to this funny Mother Tucker. She has all these great jokes, and she was telling some of the jokes, like when she has brain surgery, she tells the surgeon to keep an open mind, and all these various things like that. And I mean, it's just really funny and cute that she looks at her disease in that way, and she's able to laugh and bring some lightness to what she's doing. So I'm going to stop there, and I'm so sorry that I went over time, but I'd love it if there are any questions. I'd be happy to answer anything you guys would like to talk about. So thank you very much.